Hi, my name is KW Park from Seoul National University Hospital. My co-moderator for this interview is Dr. Michael Lee from UCLA. We would like to welcome three distinguished guests for our wrap-up interview for Antithrombotics, Dr. Takeshi Kimura, Dr. Joo-Yong Hahn, and Dr. Tullio Palmerini. I want to segment the discussion into two parts. The first part is antiplatelet therapy within the first year post-PCI, and then maybe talk about long-term secondary prevention and antiplatelet therapy. So I want to start with you, Tullio. You talked about the risk and benefit of 1 year DAPT, and a very interesting concept where within 6 months to 12 months, there was no benefit of prolonging DAPT in terms of ischemic events. However, there was a tax to pay in terms of more bleeding. However, the benefits of reduction in ischemia actually occurred post 1 year. So, what do you think is the conceptual approach that we need to have in terms of, reconciling the risk of ischemia and risk of bleeding?
So I think that stratification of risk patients is key to address this issue. So stratification is dividing patients on whether they present with acute coronary syndromes of stable ischemic heart disease, and this is the first point. And the second point is stratifying patients according to the bleeding risk. So we have to acknowledge that 1 year dual antiplatelet therapy, which is still in the guidelines, relies on old studies that do not apply to the current practice, whereas more recent data suggests that if you compare 1 year dual antiplatelet therapy with clopidogrel and aspirin versus a shorter term therapy, there is no benefit in terms of ischemic events, whereas there is an increasing risk of bleeding. So to me, current data suggests that you should really personalize the antiplatelet therapy. And if you have a patient at high bleeding risk, you can go as short as 1 month. To minimize the risk of bleeding. Whereas if the patient is a high ischemic risk and if you want to use clopidogrel, you have to go longer than 1 year.
So, I want to follow up that with another question where, what would be sort of the risk profile that you're looking for the higher risk ischemic patients? Would it be the DAPT high score patients? Would it be patients that have, high, TIMI risk, score for secondary prevention? What type of score system would you use? Because, basically you would have to continue these patients on dual antiplatelet therapy, knowing that there may be an increase in bleeding risk during 6 to 12 months.
So there are many variables that you should consider. So first of all, clinical presentation. Patients with acute coronary syndromes have higher risk of recurrency. Then complexity of coronary artery disease is another factor. Previous myocardial infarction, previous stent thrombosis. So all these factors are important in determining the ischemic risk of patients. So in this kind of patients, especially if they have more than one risk factor, you should really consider to prolong dual antiplatelet therapy beyond 1 year.
So, Dr. Kimura,
yes.
Your studies with the STOP-DAP series of trials have pioneered early monotherapy with P2Y12 inhibitors. So, what is your take with using clopidogrel alone at such an early time point after PCI? Because from the SMART studies and from your, STOP-DAP2 ACS study, there was a signal that there was, stopping DAPT very early and going to clopidogrel for ACS patients might not be such a wise decision. So
yes, actually the cardiovascular event rate in the STOP-DAP2 ACS population, it's numerically higher in the 1 month DAPT group than in the 12 month DAPT group. However, the event rate is very low, so the analysis is clearly underpowered for the comparison. So I think the most robust data set currently we have is the STOP-DAPT all patient series, 6,000 patients. That data shows the no significant increase in cardiovascular events with clear reduction of bleeding events. And also the proportion of HBL patients, high bleeding risk patients in Japan is pretty high. And the actual incidence of bleeding is much higher than the real thrombotic events, even in ACS patients. So I think in clinical practice, I think short duct will be the choice in most of the patients undergoing PCI. However, I don't know clopidogrel monotherapy is the best treatment after very short DAPT, so we should continue to find out what is the best.
So for both stable patients and for ACS patients?
Yes. Stable, for the stable patients, the result of stop TAP2 seems to be very good, but it's clearly underpowered, so it's not definitive.
Okay. Yeah, so Dr. Hahn, can you give us your opinion about, the different P2Y12 inhibitors? There's a lot of studies that have done short DAPT and then switching to P2Y12 inhibitors, mostly done in ticagrelor. The Stop DAPT2 series and the SMART series used clopidogrel as the P2Y12 inhibitor. There's also prasugrel, which I know you guys are currently performing a clinical trial on. So what is your take on the different P2Y12 inhibitors? Are there differences? What do you think is going to be the big winner? Are there going to be any differences?
Yeah, in patients with stable ischemic heart disease, we have no choice but clopidogrel, so there is no issue. But in patients with ACS, we have three different P2Y12 inhibitors: TICA, prasugrel, and clopidogrel. Ticagrelor monotherapy has some convincing data from TICO and the Twilight study. So I think the ticagrelor monotherapy is okay and it appears promising to reduce the bleeding risk without increasing recurrent ischemic events. But clopidogrel, I think some caution is needed. So there is some signal for increasing risk of recurrent ischemic events from STOP-DEP to ACS, as Dr. Kimura mentioned. And another problem is the genetic background, especially in Asia, Korea. So in Korean data, about 6% of patients have poor or intermediate metabolizer to
60%.
Yeah, 60.
Yeah, 60.
So I think the clopidogrel monotherapy after a very short duration of a DAPT is some problematic in patients with ACS. And personally, I believe prasugrel monotherapy is a very good option, but we have limited data. So nowadays, stop DAPT3 and the ultimate premium trial is conducting, so we have to wait some answers from large randomized trial.
Yeah, so I mean, I would be very, very interested to see the data from prasugrel because personally, I feel ticagrelor has the pitfall of an agent that has a pretty frequent dyspnea when we use it clinically, and you have to take it twice a day. And so if you're on ticagrelor alone and you decide not to take your, medication at night, or, because of dyspnea, you just start to not take medication at all, that sometimes can be problematic. The issue with clopidogrel, as you mentioned, is, the poor metabolizers, where about 2/3 of the population in Korea are poor metabolizers of clopidogrel. So I feel that somewhere in between, there may be a sweet spot for prasugrel, especially the lower dose prasugrel, maintenance for East Asian patients. So I would be very interested to see the data.
So I think this is a very interesting point because when prasugrel and ticagrelor have been compared head-to-head in a randomized trial in which duration of dual antiplatelet therapy was 1 year, indeed prasugrel had better results in terms of ischemic events. So according to the data we have for dual antiplatelet therapy, prasugrel has better data than ticagrelor.
And you're talking about ISTAR-REACT-5,
absolutely,
right? Yeah.
Dr. Hahn, let's say you have a patient on ticagrelor, and just out of curiosity, you do a verify now, the PRU comes back at 30, okay? So this is an LPR patient, low platelet reactivity patient. do you use that data and subsequently decide to maybe decrease the dose, understanding this patient's at increased risk of bleeding, or do you decide to go to, let's say, an alternative P2Y12 inhibitor?
Probably I keep the current management because I do not perform platelet function testing in real-world practice. So, and even if I see the results, if patients do not complain nuisance bleeding or easy bruisability, I will keep the standard dose.
Which patients do you decide to decrease it to, let's say, prasugrel 5 milligrams, or in Japan sometimes they use 2.5 milligrams and achieve
3.75. Yeah, 3.75.
Very rarely, actually, 3.75 is the usual dose.
Yeah. Reduced dose or a half dose of prasugrel is a very promising strategy, as Dr. Park and his colleagues demonstrated. But in the host to reduced polytech trial, the incidence of major bleeding was very low, and it was similar between the two groups, reduced dose and the conventional dose. And
for major bleeding.
For major bleeding.
Yeah.
But there was a higher risk of intracranial bleeding.
Yeah. And then for all bleeding, there was a definite difference.
Yeah, but
for major bleeding,
I mean major bleeding.
Continuing
And the most abundant evidence for prasugrel that we have is Triton, TIMI-38. And in that trial, they compared the prasugrel 10 milligram versus clopidogrel 75 milligram for maintenance dose. So in my practice, I prefer standard dose of prasugrel, but patients complains of easy bruisability or nuisance bleeding, I will willingly decrease the dose of prasugrel.
In the Triton TIMI-38, can you apply the results of that, which basically included most of the patients were from North America or Europe, and to apply that to East Asians?
I have no concern.
Yeah, so the maybe final question before we segue into the long-term management. So, there's a guided de-escalation versus unguided de-escalation. What is your take on platelet function tests, or do you do genetic testing? How do we adapt that into our clinical practice, or do we need to do that at all?
Well, regarding guided de-escalation therapy, I think we need more data. So to me, they are not convincing to switch practice. Mm-hmm. So we definitely need more data. Whereas there is abundant evidence that if you de-escalate to ticagrelor monotherapy, it's probably a good choice. Mm-hmm.
What about, do you guys have any opinions on guided de-escalation, or do we need guided de-escalation at all?
Yes. The platelet function test is somewhat problematic because the value of PRU is continuously changing. Yeah. But genetic information is somewhat useful, but in real world, the cost is problematic, at least in Korea.
Sure. Okay. Yeah, so I think this is a perfect time point for us to start discussing. So within the first year, we discussed, and now, what do we do, after the due duration of the APT? When we feel comfortable that our patient can, will be doing fine on single antiplatelet therapy, and we're doing for long-term secondary prevention. So the host exam trial showed that clopidogrel was superior to aspirin. So previously, most of our patients were on aspirin monotherapy after 12 months or 6 months or whatever. So, does this change your practice? How do you approach patients on chronic secondary prevention? Start with you, Tullio.
So aspirin is still in the guidelines, but as you were saying, there is growing evidence that probably monotherapy with clopidogrel is probably more effective than aspirin. So we should wait more data coming out, and then probably members of guideline will have enough data to switch recommendation. Mm-hmm. But for the meantime, I still use aspirin.
Okay. Mm-hmm. What is your practice, Dr. Kimura? Or how do you interpret the data
I
from
think in Japan also aspirin is the standard of care, but use of clopidogrel or even low dose prasugrel is becoming increasing even as a long-term therapy. And also you showed excellent data from the host exam showing the superiority of clopidogrel over aspirin. But we have to collect more data in Japanese patients, so we are now conducting 5-year follow-up of STOP-TAP2 and STOP-TAP2 ACS, comparing aspirin versus clopidogrel.
So post 1 year,
so,
right?
So we should look at that.
Once the patients are on monotherapy, right?
Yeah. But anyway, I think the long-term clopidogrel therapy is here to stay. Yeah, even without very, very strong evidence.
And what do you guys think of the differences between what the P2Y12 agent will be in the long term for chronic maintenance for secondary prevention? You know, do you think there's a room or a space for ticagrelor for secondary prevention long term?
So I think that clopidogrel is the best candidate because with increasing age, also the risk of bleeding will increase. And so I think that in this regard, so after 1 year, the risk of bleeding may remain the same or even be greater as the patient gets older. Whereas as far as you are far from the index ischemic events, the risk of ischemic events declines.
Yeah.
And so this is the reason because clopidogrel may have a better profile of safety and efficacy to be the P2Y12 inhibitors to be used as a monotherapy instead of aspirin.
Yeah, so, you know, I presented the slides today, but if you look at the Panther, collaboration and the analysis from Panther, you can see, the interaction p-value was not statistically significant. However, you can see that the spot hazard ratios were on different sides for clopidogrel versus ticagrelor. For clopidogrel, it favored P2Y12 monotherapy, but for ticagrelor, actually it was slightly towards favoring the aspirin monotherapy. So, we definitely need more data because we don't have robust data in terms of ticagrelor.
Remember the old charisma trial?
Yeah.
It was a negative trial, but if you did the sub-study analysis, the people that actually had a benefit with clopidogrel were patients with established atherosclerotic cardiovascular disease, which would follow your post-PCI patients.
Yeah.
But the data on TICA monotherapy in the Panthera study is mostly from the global leaders or Galaxy.
Yeah. And then also from cabbage trials.
Caution is needed.
Definitely. I completely agree.
I think the host exam trial is the only one relevant to trial to compare clopidogrel versus aspirin monotherapy in the contemporary era in patients undergoing PCI. There was a very excellent trial, but I think one trial is inadequate to change all the practice. As Dr. Kimura mentioned, we need more data. And one concern is, as I mentioned, the clopidogrel responsiveness or genetic profiles, especially in Korea. So in that moment, we may need a genetic guiding.
Yeah.
And actually, our group currently conducting the Smart Choice 3 trial to compare clopidogrel monotherapy versus aspirin monotherapy in stabilized but with a high ischemic risk.
So before we end, I want to touch up on just one final question. So chronic secondary prevention, the first question is, patient has an AFib. Do we go DOAC alone versus antiplatelet plus a low-dose DOAC? Second question is, for chronic therapy, do we use aspirin or clopidogrel, antiplatelet, or do we use one antiplatelet plus a very ultra-low dose of rivaroxaban? What is your take on those two issues?
So regarding the first question, I will go only with the oral anticoagulant. So especially if you are far 1 year past the index events, I think that you can use just an oral anticoagulant. So regarding adding rivaroxaban to double antiplatelet therapy, I think the effect on ischemic events is really a great effect, but there is also an increased risk of bleeding. And then it's the same issue that you have to balance the risk of ischemic events with the risk of bleeding.
For you, the ultra low dose of rivaroxaban as a chronic maintenance therapy is maybe obsolete.
Patients are aging, and therefore, as patients ages, the risk of bleeding events overcomes the risk of ischemic events.
In patients with AFib beyond 1 year after PCI, my standard regimen is standard dose of NOAC only.
Okay.
But in patients with complex lesion, left main 2 stenting or diffuse long lesion, 3 or 4 stents, at that time I sometimes add clopidogrel plus NOAC, and at that time the issue is the dose of NOAC. So I prefer standard dose of NOAC, but if patients complains minor bleeding, I reduce the dose of NOAC.
It's the sum of your dilemma in the complex patient. Do you have any opinions, Dr. Kimura?
We have actually conducted the first trial evaluating, exploring the OSC alone strategy in patients more than 1 year after stent implantation. And following the OSC alone trial, the AFIRE trial suggested the rivaroxaban monotherapy will be better than continued OSC plus antiplatelet therapy. So I think the current standard of care is OSC oral anticoagulation alone in patients with AFib and coronary artery disease. And also, as Tullio mentioned, the patients are getting older, and also renal function getting worse. And so I think the reduced dose of drug may be necessary at some time. So in the elder care trial, edoxaban 15 milligram may be very promising. So it's my favorite.
All of the microdose trials are done in Japan. So okay, so I think we had a very fruitful discussion for Antithrombotics. I want to thank Michael for co-chairing this interview, and then for all the 3 distinguished guests that we invited. Thank you for your time.
Thank you very much.
Thank you.